Thank you very much, Professor Ashraf Rida, for your introduction. And I welcome everyone. And thanks, Professor Ines, for this magnificent conference. My task is what is Pcsk9 and how it affects diabetes. My disclosure, nothing to declare. We should know that after the discovery of the proprotein convertase Pcsk9 enzyme in 2003 and its subsequent emergence as a therapeutic target is today transforming the treatment of cardiovascular disease. Just as the introduction of statins in the 1980s has significantly reduced mortality and other cardiovascular complications. Simply, in this slide, we can see here the Pcsk9, which is a natural enzyme that inhibits the LDL receptor. They are formed all together in the hepatocytes from the nucleus. It comes here, the Pcsk9 self-apposition and the LDL receptor through the endoplasmic reticulum and the Golgi apparatus. And the Pcsk9 is also going from the same nucleus from the endoplasmic reticulum to the Golgi apparatus to the outside of the cells. The importance of the LDL receptor is to accelerate the clearance of the LDL from the plasma and decreasing the LDL cholesterol, as we see from here. And the Pcsk9, misfortunately, it adheres to the LDL receptor and adhere also to the LDL molecule, and then taking it when there is high Pcsk9 or gain of function, we will see that Pcsk9 binds to the LDL receptor, going inside the hepatocytes through a glycerin-coated vesicle, and then go to the endosomes to be disintegrated. The LDL receptor is destructed. So the number of the LDL receptors on the surface are decreased and LDL cholesterol is increased. If we look for the other side there, we can see here the low Pcsk9 or the loss of function of the Pcsk9. We will find that the LDL receptor is free. And we see here that it can take the LDL particle freely through the endocytosis, endosomes, and the degradation of the LDL cholesterol, and then recycling of the LDL on the surface again 100 times per 24 hours in order to make clearance of the LDL cholesterol. There, the investigators show there is a circulating Pcsk9 and the risk of myocardial infarction, what is called the HUNT study in Norway. This study shows a very important relationship between the circulating Pcsk9 in the plasma measured by ELISA and the myocardial infarction risk, age and sex adjusted. As we see here, there are more, with the increase of the Pcsk9, there is much increased in the risk of myocardial infarction in males and females. And here we can see with adjustment of the LDL cholesterol, the MI risk, but is still present with the circulating Pcsk9. So high levels of Pcsk9 were positively but modestly associated with the risk of MI in age and sex-adjusted analysis, but the association was largely attenuated after adjustment of the LDL cholesterol. Also, this slide shows the higher Pck levels in subjects with type 2 diabetes potentially plays a role in increasing the cardiovascular outcome. As we see here in this slide, those are the diabetic, the non-diabetic, and the level of the Pck9 in nanogram. And for patients with Pck9 plus diabetes, as we see, with the increasing peptide, we find that the mortality is decreased, and the augmentation of both diabetes and high Pck9 causing hazard ratio of MACE. The Pcsk9 levels in relation to MACE in patients with different diabetic status, as we see here, with increasing tertile of the Pcsk9, we see MACE is significantly increased. Is Pcsk9 is associated with incidence of diabetes? The answer is yes. Because if you see here, this is adjusted hazard ratio, and this is the level of the Pcsk9 in nanogram per milliliter measured by ELISA. We'll find with the increase of the nanogram milliliter of Pcsk9, we'll find that the new onset diabetes is increased. Also here, we can see the predictive utility of circulating Pcsk9 levels on diabetes mellitus. Pcsk9 concentration with future diabetic incidence occurring in patients with pre-diabetes and also high in type 2 diabetes if compared to patients with normal glucose regulation. Also, we can see here that the incidence of diabetes is increased with Pcsk9 level in type 2 diabetes and also in obesity patients if compared to lean patients who have less number of Pcsk9. So the increasing number in male and female can we see here in obesity and diabetes is linked to the increase of the Pcsk9. The circulating Pcsk9 levels and incidence of type 2 diabetes is higher in women in many studies. As we see here, this is the patients without incident of type 2 diabetes and those patients with incident of type 2 diabetes in women. The p-value is highly significant, and we can see here the Pcsk9 level with increasing in women more than men. And here also we can see the sensitivity analysis of the Pcsk9 on a continuous scale and risk of incident of type 2 diabetes in female subjects who met at least 2 of the 3 glycemic criteria of prediabetes, as we see, and with adjustment of the lipid profile, liver enzymes, and the HOMA-IR, we find that increasing the Pcsk9 concentration is linked to the hazard ratio of the incident of type 2 diabetes. The positive correlation of plasma Pcsk9 levels with HbA1c in patients with type 2 diabetes, as we see here, with increasing level of Pcsk9, we find the HbA1c is much increased. The positive correlation of plasma Pcsk9 levels with HbA1c in patients with type 2 diabetes is markedly here seen, and the p-value is highly significant. Also, the HbA1c is certified by the Pcsk9 tertile in patients with type 2 diabetes. Once you adjust all the lipid profile, but the Pcsk9 is high, we can see here the highest here with increased HbA1c. لو سمحت أنا مش عارف أتكلم. This is a proposed pathway for the insulin-mediated regulation of Pcsk9. How it occurs? We can see here the insulin initiates a signaling pathway via binding to the insulin receptor on the surface of the hepatocytes. And this combination of the insulin and the RS make a stimulation of the SRBP, which upregulate the Pcsk9, as we see here, the induction of steroid regulatory element binding protein 1C, CRP. So there is a relation in patients who have hyperinsulinemia and insulin resistance and the progression and the processing of the Pcsk9 in those patients who have obesity, insulin resistance, and hyperinsulinemia. There are many landmarks trials with Pcsk9 inhibitors that show a beneficial effect with those patients. The first one is for the benefit of evolocumab in patients with established atherosclerotic cardiovascular disease, 27,000 patients with stable atherosclerotic cardiovascular disease on moderate to high dose of statin. So the primary endpoint was magnificent by about 15% reduction of the all MACE, and secondary prevention by 20% 50% in the secondary endpoint. And we see here the effect of the evolocumab, a Pcsk9 inhibitor, on the primary outcome in diabetics and non-diabetics in the Fourier trial. Those patients with diabetes at baseline using evolocumab, we can see here the number needed to treat is 37. Absolute risk reduction of MACE is 2.7 on those patients, and we can see here the hazard ratio is decreased by about 17% in patients with diabetes. It means that evolocumab as an Pcsk9 inhibitor have an effect, largely effect on diabetic patients if compared to patients without diabetes, because the hazard ratio here, the number needed to treat is 62, and the relative risk reduction is 1.6%. In the Odyssey outcomes, this is another trial using Pcsk9 inhibitor, evolocumab, benefit of evolocumab in patients with recent acute coronary syndrome, reducing the MACE by 15% and the death by 0.6 absolute risk reduction, as we see. And the diabetes worsening or diabetic complications was nil in the arm of evolocumab, as we see. And the incidence of cardiovascular events in placebo group was greater in patients with versus without diabetes, as we see. And here we can see the effect of the evolocumab as a relative and absolute risk reduction on the evolocumab by glucometabolic status. Patients with diabetes and pre-diabetes get a benefit from using the Pcsk9 inhibitor evolocumab, as we see. And here my take-home message: Pcsk9 expression is regulated by insulin via the sterol regulatory element binding protein 1C. The available evidence suggests a positive link between Pcsk9 levels with obesity and type 2 diabetes. Plasma Pcsk9 levels were higher in patients with type 2 diabetes, and moreover, the results available from epidemiological, preclinical, and clinical studies suggest a positive correlation of the circulating Pcsk9 with glycemic parameters and risk of type 2 diabetes. A positive relationship with elevated baseline circulating Pcsk9 levels and incidence of type 2 diabetes in female population with pre-diabetes. Those subjects with high circulating Pcsk9 predict increasing the cardiovascular outcomes, and targeting the Pcsk9 by Pcsk9 inhibitors showed proof in Fourier Odyssey trials the beneficial reduction in MACE among diabetics and no incidence of diabetes. And thank you very much for your attention.
Thank you, Professor Atef. And actually, you as internist or diabetologist, you will find a patient coming to you and he is on 2 injections per month, or maybe recently even 2 injections per year for something to treat cholesterol. So it's very important to understand what is Pcsk9 and what its role in lipid management, especially in diabetic patients. And as Professor Atef explained, Pcsk9 is a protein that is naturally present in our blood. And when it attaches to the LDL receptor, it prevents it from recycling in the liver. So it reduces the efficacy of LDL receptors. That's why inhibition of this protein is very important in reducing. It reduces the LDL by about 60%. And this is very important. Somebody are lucky and born with a naturally low level of this protein Pcsk9 in the blood, and these subjects usually lives to 80 and more, and maybe more, without stroke and without cardiovascular events. And some persons are unlikely and are born with high level of this Pcsk9, what's called gain of function mutation of Pcsk9 protein, and this high level of Pcsk9 in the blood of these subjects render them liable to premature atherosclerosis, to myocardial infarction in the event below the age of 55 or even 50. So, Dr. Atef, you explained the relationship between this Pcsk9 and diabetic patients, and maybe those diabetic patients have a higher level of Pcsk9 even and liable to myocardial infarction in this area. We know years ago that statin may increase the incidence of diabetes.
Yes.
I don't know whether this Pcsk9 also can do the same, or it's not related to the other.
In the beginning, on the rats, they find that the knockout rats, they induce diabetes. But in human researches, they don't find the same. And find that the Pcsk9, when it exists and circulate in the plasma, induces diabetes mellitus, but not like the Pcsk9 inhibitor. Pcsk9 inhibitors, they don't induce diabetes at all, as we see from here. But the statins on high or high intensity statin in high doses, with some population who have metabolic syndrome, have obesity, or are pre-diabetic, they get diabetes later on with the statin. But adding the Pcsk9 inhibitors prevent this phenomenon.
So I want you now to tell our colleagues here, when a diabetic patient need Pcsk9, which diabetic patient that who should be put on Pcsk9 inhibitors in his treatment?
According to the recent guidelines in the year 19, they put diabetic patients as a very high risk and high risk in the guidelines. And those patients, if they have lipid profile which is very high, or they have atherosclerotic cardiovascular disease with evidence of a serious cardiovascular disease, they have coronary artery disease, they have PCI before, they have any heart disease. Those patients, if they don't reach the target of lowering LDL cholesterol 50% and below 55 milligram per deciliter, we can use a combination therapy with adding ezetimibe. If not, we can add Pcsk9 in order to prevent the other events for those patients.
So Pcsk9 inhibitor is another weapon in the strategy of the lower the better for the high risk patient. I'm sure diabetes is one of these categories. So please join me, Atef, and I think
thank you very much.
Thank you, Professor Atef.